There is a pilot program which will study opioid addiction treatment in 7 jails in Massachusetts. The study will look at outcomes for inmates who receive medication. Dr. Peter Freidmann, Associate Dean of Research at UMass Worcester and Chief Research Officer at Bay State Health, and Elizabeth Evans, Assistant Professor at UMass Amherst School of Public Health and Health Sciences, joined me in studio to explain.
Over 5 years, we've been awarded about $10 million as part of a huge initiative from the National Institutes of Health called the Healing Communities. Healing stands for helping end addiction long term. And this is focused on the criminal justice system. In particular, it's part of their mechanism, which they call J-Coin, and you'll hear us refer to J-Coin, which stands for the Justice Community Opioid Innovation Network. And we are one of 10 sites around the country funded to actually evaluate various interventions in the criminal justice system to address the opioid crisis.
And when you say interventions, these are medical interventions, right, with inmates?
Yeah, primarily they are interested in increasing the amount of medication treatment that is made available to inmates, both within facilities, but also when folks transition back to the community, that we increase the amount of medication treatment that's available for folks with opioid use disorder, because that is one of the few things that's really been shown to reduce overdose deaths.
So Elizabeth, I know you have been involved in further research as well involving Franklin and Hampshire counties, and I think this now kind of rolls all of this into one. Tell us a little bit about what Franklin and Hampshire County had been doing already.
Yeah, so they're one of the few jails in the nation to be implementing these medications to address opioid use disorder. And so I started a project with them about 1.5 years ago where one jail is teaching another how to go about delivering these medications in a way that works well. So now they're a part of this new effort, and they're joining 7 other jails as a part of this J-Coin effort. And they're the jails that really step forward to say, we want to pilot test this innovative program and figure out how can we do this well and what can we learn from implementing medications in the jails. So it's part of this new law that was passed in Massachusetts about 1 year ago or so, called Chapter 208, that's being implemented as of September 1st. So for some jails, it represents a pretty big change in how they go about doing what it is that they do, and we're being brought on board to help understand what are the outcomes, what works well, what could be improved, and what are the costs and maybe savings associated with that programming.
And Hampden County is also part of this study as well.
Yeah, there's 7 counties altogether. Both Hampden, Franklin, and Hampshire are part of the 7 counties.
Okay, and when you talked about medication really being looked at as the way to reduce opioid deaths, what had been happening or prior to this in a jail setting when somebody would be locked up and go to jail?
Yeah, so around in most of the country, still in most jails in Massachusetts, the standard was if somebody has an opiate use disorder and is incarcerated, they are promptly detoxified, is the term, we call it withdrawn, from their either street opiate or even if they were on medication in the community, if they were on methadone or buprenorphine, they were promptly taken off the medication. There have been a number of lawsuits about the latter that represents, the jails not meeting the community standard of care for folks with these disorders. So typically folks have been taken off their medication, and what happens is when you take people off their medication or when you remove their street opiate, what happens is they lose their tolerance. So what tolerance is if someone has a chronic history of use of opiates, you need more and more in order to get the same effect. So what happens then is you reduce their tolerance so that when people go back to the community, if they use anywhere near what they were using before, that represents that will produce an overdose. So the notion is that we want to maintain folks' tolerance. We want to keep those receptors, those opiate receptors blocked, and that will prevent folks from overdosing during the period immediately after release back to the community. And there have been many studies now that have shown that the highest risk period for folks actually is the period after they've left jail or prison, having been detoxified and going back to the community. So the notion is that will be a major step in reducing overdose deaths in the community.
How long does a person have to be on methadone, for example, before they can live without it?
Well, that varies greatly, and a lot of us in the field take issue with sort of that framing of the question. It's sort of like saying to somebody, how long does somebody need to be on an antidepressant before they can come off it? Or how long does somebody who has high blood pressure need to be on high blood pressure medicine? Or how long does somebody who has diabetes, how long do they need to be on insulin? We never ask those questions about those diseases. We only ask it about this disease.
But I think because people don't understand it.
Right.
People don't understand it, and this is new, and this treatment is not new, but just this whole focus is new.
Right.
So that's it. It could vary for people. Is that what you're saying?
Well, what I'm saying is, and you're right, people don't understand. People have a view of addiction traditionally as an acute illness, that it's like pneumonia. You give someone antibiotics for a short period of time, and then they come off, and then they're cured. It's more akin to a chronic illness. These changes in the brain and the receptors are chronic, long-term changes, and very hard to reverse. So people often need medication lifelong, like they do for blood pressure or diabetes. They need insulin for diabetes. There are some cases, though, particularly folks who've had either relatively mild forms of the disease or very short-term use. Those folks can, in some cases, come off. But I think a lot of the more challenging cases we're dealing with, a lot of those folks are going to need to be on medication for quite some time.
Yeah. And what are you hearing from sheriffs and others that work in the jail about this method of treatment?
Yeah, I think they're excited to be a part of this new project. They're very eager to learn how do we do this well, but they also recognize there's some challenges that they need to work out. So we want to work with them to understand what are those challenges, how can we maybe take practices that have been known to work elsewhere and implement them here. So it is really exciting to be a part of what it is that they're doing, and that they're so receptive and eager to figure out how to deliver these medications to this population.
And there's been such a focus, obviously, as there should be, on the opioid crisis in Massachusetts. Numbers have gone down for deaths. I know in Springfield last year they went up. Mm-hmm. Fentanyl seems to be the issue. Yes. So that's still, the prevailing issue, would you say?
Yeah, so what I was saying before, when people lose their tolerance coming out of jail, part of it is if they go back to using before. But the other issue with street sources is folks really don't know what they're getting and what the strength is or potency is of what they're getting on the street. And what we saw, particularly in the early part of 2018, was a particularly potent fentanyl that was introduced or being introduced into the community that was adulterating the heroin supply. People thought they were getting heroin. They're really getting fentanyl, and there were a large number of overdoses.